my name is Samia Mora. I'm a cardiologist at the Brigham and Women's Hospital, and now we are part of Mass General Brigham in Boston, Massachusetts. I'm also a professor of medicine at Harvard Medical School and president-elect of the IAS, and it's really my great pleasure to be with you today. And you are the future of IAS, so this is just the beginning, hopefully, or continuation of your journey with us if you've already been with us. So welcome. And today I'll be talking about LPA and inflammation and cardiovascular disease. These are some of the disclosures. Probably the relevant one here is Jupiter trial was funded by AstraZeneca, because I'll show one slide from Jupiter. Okay, LPA, inflammation, cardiovascular disease. So there's 4 topics. First, I'll touch base on some global challenges of cardiovascular disease. Then we'll talk about specifically lipoprotein little a and cardiovascular disease. And then we'll talk about potential mechanisms, and we'll discuss some of the inflammatory functions that have been attributed to LP little a. And then we'll discuss more the clinical impact, because I know we have a variety of people in the audience today. Some of you are clinicians and some of you are more researchers. So first, global challenges. Well, Peter took us back to Cornelius Celsius in the 1st century AD. I'm taking you back even further, so we're going back 3,500 years ago, to both Egypt and to the Assyrians. So the ancient Assyrians and the ancient Egyptians actually documented for us. I mean, probably many other cultures also had discovered this already, but these are the documented findings about inflammation. So this is the earliest mention of inflammation, and also inflammation and anti-inflammatory therapies, which is aspirin at the time, because as we know, aspirin came from the willow tree, from the bark or from the leaves as a compound, and then was formulated by Bayer in Germany back about more than 100 years ago now. But it actually comes from the willow tree. And both in the Ebers Papyrus and also in the Sumerian tablets, it's been documented about inflammation, anti-inflammatory therapy, and this is translated from that. When you examine a man with an irregular wound and that wound is inflamed, there is a concentration of heat. The lips of that wound are reddened. These are the characteristics that Peter mentioned. The man is hot in consequence. Then you must make cooling substances for him to draw the heat out. So anti-inflammatory therapy, which is the leaves of the willow. Other remedies of interest was onion crushed with honey and taken with a beer. So now fast forward to current date. This is the latest data about the prevalence of cardiovascular disease. This is from the Circulation 2025 AHA statistics. So you can see the prevalence of cardiovascular disease ranges globally. I know we have global representation here, so you can pick your country or favorite continent. But you can see there's a range. The highest prevalence is currently in the Middle East, North Africa, but also you can see orange and yellow quite a bit in Russia and other parts of Asia and Africa, also even in North America and South America. So it's like everywhere. If you look at the age standardized rates, they actually differ by region. And this is one of the global challenges, especially for those of you, especially today, who are either working on or are from those countries that are predominantly affected by cardiovascular disease. So if you look at the global age standardized death, you can see that ischemic, so this is now just coronary without looking at stroke. So ischemic coronary heart disease kills about 100 out of every 100,000 globally. Now, if you look at certain areas like Central Europe, East Europe, Central Asia, that number is double. It's 215. Double the global. If you look at high income, for example, North America, it's half, so it's 51, so it's half the global rate. So that means that there are some areas that are 4 times, the high income rates. That's Central Eastern Europe and Central Asia, and also North Africa, Middle East, which is 200, again, double the international rate. South Asia is also quite high, but not as high, but it's 150. So these are the current mortality. These are just from ischemic, so coronary, basically MI. Now, what's projected? Is there good news or bad news going forward? Well, this is why we need you all, because moving forward, it's actually going to be even worse. This is projected global cardiovascular mortality to 2050, and you can see now the red is growing even bigger. Now, it doesn't mean the other areas don't have, it just means they're lower relatively. The highest area is actually projected to be, this is data from last year, projections from the from the Global Burden of Disease study, the GBD study. So projected to be Central Europe, Eastern Europe, Central Asia to be 300 out of 100,000. So again, really high. But also you can see there, North Africa, Middle East, 243, South Asia, 200, Southeast Asia, East Asia, Oceania, 232, Sub-Saharan Africa is 230. So that's quite a bit of mortality just from cardiovascular disease. This one here would include also stroke in it. So what's inflammation got to do with it? Well, could inflammation, as Peter already set the stage earlier, be the cause of many myriad conditions that are also predisposing to this rise in cardiovascular disease? If hashtag chronic inflammatory disorders, I got this this hashtag from Roger Blumenthal, but you can see multiple inflammatory conditions shown on the slide that share all, in terms of inflammation, and this is the atheroma and the aorta. You can see it's also, now we know it's a very inflammatory condition as well. So what's the role of LPA in all of this? So let's talk about LPA. Well, first, there is global, there are some differences by ethnicities in LPA specifically, and it's related to the genetics. So, because LPA, as was mentioned earlier, is predominantly genetic. It's like probably up to about 90% of LPA levels that are circulating are driven by the underlying genetics, mostly in the LPA locus. Now, if you look at this, this slide here, what's considered high, like you can have 20 or 30% estimated prevalence worldwide, depending on which region you are. For example, estimated in Africa to be 30%. Again, that's if you use a specific cut point. Keep in mind, LPA, there are two different, well, actually there's more than two, but the two commonly used assays. One is a mass-based assay, that's the milligram per deciliter, because you're measuring basically the whole particle weight. And then the nanomole per liter, which is you're counting the number of particles. So one is counting how many LPA particles do I have per unit volume. The other one is counting, well, how much weight do I have of the whole particle. So these are the currently considered high, more than 50 milligrams per deciliter or more than 125 nanomoles per liter. They cannot be converted between each other, so it's not like there isn't an actual conversion factor because of complex reasons that we can, if there's time, we can discuss. Okay, so also again, summarized here is, this is from Borg Nordisgaard, some LPA levels by geographic region. So actually some of the highest are from individuals of African ancestry, and you can see in those individuals, those levels are higher than others. South Asia is next, and then Middle East is also high. Again, quite a variability. There isn't as much data in those areas as well. So most of the data we have is really from European population. So we need actually more data so that this is examined more. Now this is. Why do we care about LPA? It's because it's related to cardiovascular risk. Now, as was mentioned earlier, there's a lot of biomarkers that are related to cardiovascular risk. So Jessica's question earlier, well, which one do you look at and why do we look more at LPA? And I think this pendulum has swung for LPA over the past 20 years because we now realize that LPA is causal, or we are almost sure of that. And that's based on the genetic studies. Like there's been consistent Mendelian randomization studies, there's been consistent other genetic studies. Now what's still missing is the part about, well, if we lower specifically LPA and only LPA, do we get reductions in clinical events? That's the part that we're still missing in the causality piece, and that hopefully we'll know soon. But based on the data we have currently, if you look at associations of LPA, so going here to the right is higher level. So you can see there are different outcomes here. MI, top left, ischemic stroke here, heart failure, aortic valve stenosis. The strongest relationships you see are for MI and for aortic valve stenosis. Those are the strongest, right? Then you look, ischemic stroke, there is association, it's a bit weaker, but at the very highest levels of LPA, there's a relationship with ischemic stroke. And heart failure, tracks sort of myocardial infarction because nowadays most of heart failure currently, at least in European populations, is driven by underlying ischemic cardiovascular disease. So that's why it tracks with that, because it's mostly like sort of secondary to MI. But keep in mind also there's a lot of, it's a causal relationship also it seems with aortic valve stenosis based on the genetic data as well. This is a graph like showing the lifetime risk for MACE, major adverse cardiovascular events based on LPA levels, again a gradation of risk, and you can see, because it's a genetic factor, we have it from when we were born, so the risk is cumulative over time. And this study, I think you saw earlier, this part of the slide, the CRP relationship, this is data from the Women's Health Study, which is housed with us in Boston. I'm actually co-PI also of the Women's Health Study. So if any of you are interested, we're open to, we actually welcome people to put in proposals, etc. So you can just go to the Women's Health Study website online, and there's a part there for investigators, and you can look at the data. All the data is there, and you can, put in a proposal, etc. So we welcome you as well. Now we have 30-year follow-up on these women, and we have about 28,000 who have been followed. Now we still have about 20,000 of them alive, but they've been followed now for over 30 years. And this is the data that was earlier mentioned about CRP being, predictor of cardiovascular events in these women with, on average, about 20% increased risk per standard deviation increment in CRP. And if you look at LPA, you also see there's a graded risk, especially in the higher levels of LPA. For example, the top quintile, which was 44, in this case more than 44 milligram per deciliter. It seems a bit less than CRP, but they are cumulative and they're independent. So while CRP is correlated with other risk factors, LPA is really unique in terms of it doesn't really correlate with any other risk factors, of the standard cardiovascular risk factors that we know about. And their additive risk. So in this slide here, also from Paul's data, if you have like 3, and the third one was LDL cholesterol. So if you have LDL cholesterol, CRP elevated, and LPA elevated, you had about a 4-fold risk over these 30 years. And this is just one study. There's many other studies, but just to show you the very long-term risk as well. And Jupiter was mentioned earlier. I was actually on the clinical coordinating committee. This was actually one of the first studies I got involved with at the Brigham when I was junior faculty. And we wanted, as you know, Jupiter was really testing whether among people with chronic inflammation, for whatever reason, their CRP was above 2 milligrams per liter. They were recruited and their LDL cholesterol was not high, but it wasn't low. I mean, it had to be less than 130 milligram per deciliter. But among those individuals, they were randomized to Rasuva versus placebo, and Rosuvastatin at high-intensity dose reduced cardiovascular events by about 50% or so. Now, we looked to see, at that time, when we actually published this paper, this was published about 10 years ago, Amit Khera was a postdoctoral fellow working at the Brigham with us, and at this time, I submitted a grant to multiple funding agencies. I'm saying this, sharing my story just because it's really hard to get grant funding nowadays for many people. So, and when I submitted this grant, the grant reviewers' comments, they basically rejected the proposal. And they basically said, you're not going to, once LDL cholesterol is low, like in Jupiter, on average reduction was, we got down to 54. This was on treatment. So they said, well, once you give somebody high-intensity statin and they're already primary prevention, so, kind of lower risk than secondary, you're not going to have enough cardiovascular events to show any relationship to any of the biomarkers you have. So we got rejected. We still managed to do the study, actually, because it was a collaboration with Quest Diagnostics, and they ran for us the assay. We absorbed the cost of sending them the samples. So we still did that. And this has actually been one of my, higher cited papers. This is, again, just example that you can, if you have an idea or a thought, try to persist in it, even if people reject it. And so what we did find was actually, in fact, among those people whose LDL cholesterol was reduced, there was a very strong relationship between the LPA level and cardiovascular events. Again, here it's like a 27% increase per standard deviation. This was after adjusting for everything else, including the on-treatment LDL cholesterol, CRP, etc., BMI, whatever you like. And it even seemed a little bit stronger among the people who were on the statin compared to placebo, but that wasn't significantly different. So this was actually a new finding, because up to that point, people thought, well, LPA risk carries only risk among individuals with high LDL cholesterol, not with low. And then also now that study also, our finding has been corroborated also in secondary prevention and other populations that got treated to low LDL cholesterol levels. So let's talk about inflammation, because that's, I know, the focus of today's meeting. And what's the role of LPA? What do we know, at least, about the role? Because the role of LPA still is a molecule that, or actually a set of molecules, because it's not just one. Every one of us, it's codominant, so we inherit from both our mother's side and our father's side, and it depends on what we get in terms of the LPA locus, etc. And it's really a set of molecules, a set of lipoprotein molecules. And we hear a lot if you read papers, it says LDL-like. Well, it has some similarities to LDL, but it's not really an LDL particle. I just want to bring that home. It's not really LDL, but it has some similarities to LDL or other lipoproteins. So the similarities are this part here. So it's basically the middle part is like the LDL, because you see there's ApoB100, and we know like the atherogenic particles carry ApoB. And then you also have the phospholipids, you have the cholesterol, you have triglycerides in it, and you have this OXPL. These are these circles here, oxidized phospholipids, shown in these circles on this graph. And so this is how it resembles a LDL particle. But then in addition, it has this component here, which is a schematic of it. It really kind of wraps around the particle. And this part here is the ApoA. So apolittle-A, because that's different from like apolipoprotein big A, which is actually is more like the HDL that's on the HDL particles. So apolittle-A is basically this here. And what you see on it is that there's this part here, it says P. That part is sort of like homologous with plasminogen. So that's why the thought initially was that maybe LPA is prothrombotic. As you can see here, question mark, is it prothrombotic? Or really more accurate is it antifibrinolytic? Because as was mentioned earlier, plasminogen activator, like TPA, right? Tissue plasminogen activator is the strongest molecule we give to break up the clot. So it's really a fibrinolytic. So could this be interfering with plasminogen activity, and therefore you have less plasminogen activation, less clot breakup? That's one hypothesis. This has been borne out a little bit in some of the experimental and animal studies, but not in human studies. So, and also not with the genetic or Mendelian randomization studies. So that's why this part has been kind of more question mark. And there are also differences between LPA that's, say, expressed due to genetic experiments in animals versus LPA that's in humans naturally. By the way, LPA is only found in humans, primates, and like hedgehogs. So it's not found in all the animals naturally. So here you have kringles. See these kringles? And they're called kringles because they kind of look like, I think there were some Danish kringles out there, I can't remember. But they kind of look like the Danish kringle pastry. And there's different types, numbers. You can see like type 10 here is the one that carries the oxidized phospholipids. As you can see here, oxphospholipid is near the kringle 10. But there's also a kringle 4 type 10. There's other kringle 4 types here, and the one that has a lot of repeats is kringle 4 type 2, which is this one here. You can see how there's multiple of them. Like here they show 4, but in other individual maybe 5 or maybe 10 or 20 or a lot more. And depending on how many you have of this kringle 4 type 2 repeats, these ones, then that makes the particle bigger or smaller, and that also affects the concentration in the plasma. So if you have many of them, the particle is bigger. And it turns out to be that when you have bigger particles, you actually have lower concentration. It's inversely proportional to the concentration in the blood, and vice versa. Now, other aspects of inflammation and function is thought to be this pro-inflammatory through the oxidized phospholipid. Again, we said there's these oxidized phospholipids here, but there's also oxidized phospholipid here, which is near the kringle 4 type 10. And that's thought maybe to be the main function, and they're different, right? Because you have this one here and this one here may have actually even two different functions, both pro-inflammatory. So how could it be pro-inflammatory? We'll talk about that, but it could be through cytokine release, macrophage function, and also through the endothelium. Could also be pro-atherogenic through the binding to the endothelial cells, promoting smooth muscle proliferation, and also calcification, lesion calcification is another mechanism. So there's many potential, but it's still there's still an area of active research, and any or all of them could be involved. We still don't know for sure. This is another slide. Thank you, Peter, for sending me this recent review by Pfefferman et al. And again, there's the LPA particle. There's that protease domain that's similar to plasminogen. There's plasminogen here. So one idea is that maybe, again, this ApoA part, because it's a similar structure, it inhibits the plasminogen, so it inhibits activation of plasminogen, and therefore you don't have this fibrinolytic function anymore. But it could also be that, because of the cholesterol, because it carries cholesterol. It doesn't actually carry LDL cholesterol, it just carries, this is actually really wrong, but it carries cholesterol. So it is possible that the cholesterol in the LPA goes and deposits in the atheroma as well. And it also is possible that it's because of its pro-inflammatory function, again, through multiple pathways, through cytokine release, monocytes, macrophages, endothelial function, etc., can also all be contributing, and it could all be also, together. It's not like exclusive. In this other review, this is a review also on oxidized phospholipid on LPA specifically, and here they put the function of the oxidized phospholipid in these boxes. So these are potential functions for the oxidized phospholipids, where they could be both acting on macrophages, as well as endothelial function, migration of macrophages, and also adhesion molecules, monocytes, inflammation. You can see there IL-6 also, TNF. So basically it could be many things. In addition, I want to highlight here, there's a role for calcification also. So oxidized phospholipids seem to be also promoting calcifications and microcalcification and this osteogenic differentiation. So this may be how the aortic valve stenosis is happening. Or at least in relation to LPA. There are some other studies, I just wanted to highlight some here, which is that the oxidized phospholipid could be having different functions in different particles. As I mentioned, oxidized phospholipid is also present on LDL particles. As I showed you on LPA, it's present on two things. Part of it is the main particle, and part of it is the ApoA. So it is possible that the ApoA part of the oxidized phospholipid, but not the oxidized phospholipid on LDL, in this experiment stimulated IL-8 expression in macrophages, as shown here. So it is, it is possible that they have different functions. In this other study here, they took individuals with LPA levels that ranged, average was about 108 milligram per deciliter. So it ranged from 50 up to 195. So these patients, and then they scanned them. They did some of the FDG PET scanning that earlier Jessica mentioned, and they also did SPECT CT here with labeled PBMCs. And basically, the bottom line is that there was increased arterial wall inflammation, as imaged here, among these individuals with high LPA compared to normal LPA. So that was also, this is human experiments. And then there's also, again, like I said, there's potentially a role in monocyte migration, endothelium, monocyte and LPA also transmigration here and depositing the cholesterol. So there's like complex pathways that this could be involved in. We also summarized this with Zareen Faruqi in this commentary that we had in European Heart Journal last year, where postulating what's the link between LPA, inflammation, in the human population studies, and is it through the IL-6, because we know that IL-6 is upstream of CRP, And we know also that IL-6 can also promote LPA production. Whether or not LPA production also can promote IL-6, that's sort of a bit more of a question mark. But we know that the oxidized phospholipid on LPA, as I mentioned, are involved all inflammation. And could that be how there is this relationship with ischemic heart disease? There are several studies that have suggested maybe the LPA relationship with CVD is modulated by inflammation or not. That's still kind of a bit controversial because I've seen both studies. Some studies suggest that the relationship is regardless of inflammation, and some suggest that if you have more inflammation, then the relationship for LPA is stronger with cardiovascular risk. Okay, so in the last, I think we're getting to the end of the talk. Let's talk about some of the clinical aspects. So first, clinically, in the study from Copenhagen Heart Study, they looked at the correlation of basically they looked at the LPA levels on the y-axis and CRP on the x-axis. And you can see among individuals with higher and higher CRP, even going to more than 10, on average, when they grouped these populations into subgroups, they found basically very similar LPA. So it suggests that it doesn't negate it, but it suggests that there isn't a huge difference for LPA levels across the CRP. So for example, CRP more than 10, the average LPA was 21 versus it was 18 in those with very low CRP. So and again, it's not correlated really with CRP. And neither did it modify, so this is one of the studies where it did not modify the relationship with CVD. There was similar relationship of LPA with CVD regardless of the inflammatory, whether the CRP was high or low, etc. How about post-acute coronary syndrome? Because these people are really inflamed. These patients have a lot of inflammation, right? They just had their heart attack. So, for example, if you take Odyssey outcomes and they recruited patients after ACS, post-acute coronary syndrome, and in this case, Odyssey outcomes repeated the blood work about a year later. And you can see actually if you look just at the placebo in blue, the levels were very similar. I mean, maybe they were a bit higher initially. So this was the starting LPA baseline. And maybe it dropped a bit by month 4, but kind of not a huge difference, right? We're not talking dramatic difference. Of course, aliricimab, the PCSK9 monoclonal inhibitor, did reduce LPA by about 20% or so. And that's known in other studies as well, like with other PCSK9 inhibitors. Also in Jupiter, remember I told you Jupiter, we recruited patients based on their inflammatory profile. So we had a range of inflammation. We had a range of inflammation at baseline, and we followed the individuals. So we looked actually to correlate their CRP levels. The median baseline was about 4 for CRP, and we looked to correlate it over time. So if you look at LPA level, if you just take the LPA level and you look at it over time, it's very stable. It's like 0.95. So I took my own blood and I repeated it over time, and it was like almost the same LPA level. Now, it is true that there are some secondary causes that can modulate LPA levels, and of course some drugs that can modulate it. But aside from that, if people are generally not treated with any of those that specifically affect LPA, in general, the level stays very correlated. That's why the guidelines have tended to say you can just measure it once. But of course, there are always exceptions to the rules. So sometimes there are other factors that can modify it, like kidney disease or liver disease, or some hormones like thyroid, or even some of the testosterone, things like that can actually affect it. How about for cholesterol or lipid lowering agents? Well, what do statins do? Actually, in Jupiter, that was the study that I just showed you. We did show that on average, the statin did not have an effect on the average LPA. The median was not changed. The LPA median was not changed, but the distribution shifted a bit positively with the statin, suggesting that there are some individuals who contributed to that shift. And it turned out to be mostly the people with very high LPA levels. Some of them increased while they were on a statin. And some other studies have also shown that. So now we know that there are some individuals whose LPA may go up, especially if they start out with a very high LPA. But on average, they doesn't change. So that's why here statin reduces, say, for example, LDL cholesterol by 50%, but has very minimal effect on LPA. Like I said, on average, there are some individuals who have variation. How about inflammation? So anti-IL-6 here that actually reduces LPA by about 30%, but has not much effect on cholesterol. You can see there's no reduction in cholesterol, but has a substantial reduction, like 30% in LPA. There are other agents or other methods, procedures like apheresis. Apheresis, for example, will reduce both. Will reduce LDL cholesterol by about 60-70%, and also LPA by like about 70% initially, and on time average is about 30-40%. PCSK9, as I showed you, reduces LPA also again 20% or so. CETP inhibitors, so for example, orbicetrapib, which is now being, there's I think data, a lot of emerging data there that's interesting, and that also reduces both LDL cholesterol and LPA. So just showed you here some various effects of some of the therapies. PCSK9, so some of the monoclonal inhibitors, they did this one study where they looked to see was there any arterial inflammation. I showed you the other study where it showed that people with high LPA had arterial inflammation. Well, now they tried to see this other study, well, if you give PCSK9 monoclonal antibody, does that reduce inflammation in the artery wall? And it turned out it didn't. It reduced the LPA by about 14%. It reduced LDL cholesterol, but there was no change in this one study in the arterial inflammation as measured by imaging. However, when an ASO, antisense oligonucleotide, was used that targets LPA specifically, as shown here, this is basically the pelacarsen, it did reduce inflammation. So it's just possible, it's still an area we don't know much about, but it's just possible that there is reduction with these LPA targeting therapeutics that reduce also inflammation, not just LPA. Now, how do we put this clinically? With Florian Cronenberg, we wrote a nice summary for clinicians in JAMA, Clinical Insights, and basically there we suggested that you can use, because it's genetic and because it doesn't correlate with other biomarkers, you can basically use the risk from LPA and multiply it by the risk from the other risk factors. Now you cannot do this multiplication if somebody has a risk factor here, like why can't you do it with CRP? Because CRP also correlates with cholesterol, with especially say triglycerides, HDL, etc. LPA is really not correlated with any of the other ones. So you can take the risk from LPA, and then you can take the risk from all the other traditional risk factors, and you can multiply the two because they're multiplicative risks. And then you can kind of estimate that in your clinical practice. So for example, you can use a score, or in this case, you can use AHA Prevent now, or whatever is your favorite way of assessing patients' risk. So for example, you assess the risk to be 5% at baseline, and then you can measure LPA. If LPA is 7 milligram per deciliter, that's low. If it's, say, 150, that's high. So what's the risk from that? You can estimate it based on the studies. So we estimated 150 is about 2.7. So you can multiply that 2.7 by the 5%, and you get this added, 2.7 times 5, and then you add it to that, so you get about 14%. Now, this may sound complex, but basically the bottom line is, if your LPA is about 50 milligrams per deciliter, you can multiply by about 50%, 40-50% the risk, and then you have to add it to the other risk. And then if its LPA is 150 milligrams, that's about a threefold. But if you don't, can't remember these, I can never remember these numbers, I can always look them up. There's actually an app out there called lpaclinicalguidance.org, I think, or .com, and you can get the actual number there. That one is based on the UK Biobank data. Just briefly, also, LPA is part of the risk enhancers that are considered by HA guidelines. These guidelines are being revised, so we'll see what the updated guidelines say. But as you see here, this is the LPA, but also they have CRP there as the biomarker, and also they have chronic inflammatory conditions as another category, and also metabolic syndrome, which also has also inflammation in it. So you can see there's different ways that inflammation is part of the risk. And with the EAS, it was really my great pleasure, as Peter mentioned earlier, to co-chair the EAS position paper on LPA, and we came out with a consensus on LPA. This was about 2 years ago now. And in it, we basically say we should measure LPA because it's causal, it's common, it contributes to risk of ASCVD, but also aortic stenosis, and we can act on it, and you can ask how we can reduce all the other risk factors. And now we're waiting also for the targeted therapies. However, if you look at clinical practice, this is in California, LPA testing is rarely done. Like I know even at the Brigham, this is actually the case. So it's not just because it's California, but it is very few. Even among those with a family history or personal history of CVD, only like 2, 3, 4%. And I think it's like that globally. We were on an LPA summit in Brussels not too long ago, and we heard worldwide data, and also very rarely does it get measured clinically. I think that is changing because of all the guideline changes, but it will take time to catch up. Now, we know there are now some specific therapies, and I think that's why we kind of, all the guidelines have gone towards measuring LPAs kind of in anticipation that we hope some of these would work. We don't know yet in terms of clinical cardiovascular events, but we do know that they reduce LPA quite a bit, dramatically, even up to like 99% with some of them, depending on the dose. There's basically two ways to target them, but it's basically targeting the production of the LPA. And the production of the LPA is in the liver, because LPA is produced in the liver, mostly, for the most part. So that's how you have the therapies that target it, specifically to lower it. So there's ASO and there's siRNA. And we don't have much time to go in depth, but basically the ASO is pelacarsen. That's the one that will have the first data out probably early next year. And then some of the siRNAs are shown here: lepidisiran, olpasiran, zerlarseran, which is silencing technology. These also are longer acting. That's one of the advantage of them. There's also some oral. These are all injection subcutaneously. There's oral inhibitors, muvalaplin as well, that reduces also LPA specifically by quite a bit. These are summarized here with some of the trials ongoing and when we're expected to find out. I don't want to read them for you, but you can take a look. Just one final thing about LPA. The question comes up always: is a very low LPA safe? Like, because there must be a function for it. I showed you all the kind of potentially bad functions for it, but is there another role, a physiologic role for it? We don't know that for sure. But actually now in 2010, we published this paper actually looking data also from the women's health study that I mentioned earlier, and we found we were surprised. We actually were looking at LPA. We hypothesized that LPA will also be associated with increased risk of diabetes, because most things that associate with cardiovascular disease tend to have increased risk of diabetes. That was the hypothesis. Actually, it was my hypothesis. And then it turned out to be wrong. It turned out to be the opposite. Actually, was lower risk of diabetes. So we were very surprised about this finding, and we weren't sure to believe it or not. Neither were the journal reviewers, by the way. So we didn't get luck publishing it until we got it then finally into clinical chemistry, because we replicated it with Borg study in Copenhagen. We had the same finding. They said it must be due to like something that you're not measuring. I mean, we have so many other biomarkers in women's health study. We put them all in the model. Like, it just, nothing wiped it away. But basically what we found is people with very, very low, the bottom quintile is like about less than 5 milligram per deciliter. So really low. These individuals had, as you can see here, increased risk for diabetes. And this now has been confirmed with all these other studies that came out after. And in fact, actually, for the IAS consensus, I updated, and we did an updated meta-analysis of this. And you can see on average there's about a 40% increased risk of type 2 diabetes with very low LPA. And now here we have like 10,000 cases of diabetes in this meta-analysis. And then the genetic studies also confirm it. There's some like Mendelian randomization, as well as other studies that also confirm this finding. So it does seem to be causal, but whether or not we will find this clinically in the trials, we'll have to wait and see. It is being tracked as an outcome in the trials, so it'll be interesting to see. And just to summarize the IAS, what can we do? Because we said we can do early traditional risk factors. So we cannot right now specifically lower LP, or at least we don't have the data to tell us we should use those agents yet, but we can do all the traditional risk factor because we know LPA risk is genetic, we know the risk starts early, we know also atherosclerosis starts early, so let's try to treat it early. And we treat it by reducing all the other risk factors, really. So, and potentially in some patients with very high LPA, we could use PCSK9 inhibitors. We can also, there's some data for low dose aspirin. There's now 2 trials, actually one from the Women's Health Study and one from another, the Esprit trial, that also suggested that maybe there's benefit among those with very high LPA. Apheresis is another FDA indication, FDA approved. It's used, I think, in Germany quite a bit. We don't really use it in the US that frequently, but now it is considered, it is an FDA, it is, it is FDA approved for patients with high LPA. In fact, actually not very, very high, but like LPA more than 60 milligrams per deciliter. And progressive clinical disease, even despite optimal therapy. So that is one of the FDA indications. So summary, there's strong evidence for LPA relationship with atherosclerotic cardiovascular disease, also with aortic stenosis, which we didn't get into too much. The clinical management, basically we're recommending that LPA should be measured at least once everywhere. This is genetic, so if you find a patient who does have a high LPA, we should screen their family members. This should be like cascade screening as well, just because right now we don't have everybody screened in the whole population. So that's one way to target more. And it gives them idea about their risk. Some people do have early cardiovascular disease. They can, really try to control aggressively the other risk factors to lower their overall risk. So for patients, this is a really important matter because a lot of times they discover it after they've been, like why? Like they were, say, healthy, they're runners, their BMI is normal, everything they're doing is right. Why did they get an MI at age 30, And often it turns out to be like, say, it's the LPA. And we still await the therapies from the phase 3 trials to know whether they reduce clinical cardiovascular events. So that's basically what we discussed today, and I'm happy to take any questions and answers.